Thank you very much, Horace. I appreciate that. I apologize, no Espanol for me, sorry. But thank you for coming today. It's wonderful to be here at this wonderful Congress and be a part of what's happening in Latin America around training and certification and recertification. So it's quite an honor for the Global Pediatric Education Consortium to participate in this event. I wanted to today is spend a few minutes. We have what, 2 hours? Okay, 15 minutes. 1 hour. I won't take that whole time though, so you can do other things. But I want to take a little time and lay the foundation of what the GPEC is and what it is not. And so you have an understanding of what's happening here in the southern cone of Latin America. It's really quite encouraging to the global community of pediatrics to see what's happening in South America, because it's something that has not happened before in any other medical specialty, and that is the promotion of global standards for training and practice in a specialty. So pediatrics is leading the way in this effort, and it's, I was telling someone at dinner the other night that in the United States we're very proud that pediatrics many times leads the way in very large efforts. So it's gratifying to see the same thing happening around the world. Pediatrics is a small specialty, but big power. So let me begin. First, my disclaimer. I did translate the slides for you, but if the translation is poor, it's Bill Gates' fault, not mine, okay? So, the GPEC was initiated in 2009, and there are a couple of important statements that the global community wanted to make in our vision statement. And one of them was that the span of responsibility of the pediatrician is from birth into the transition of adulthood. And we did that for a number of reasons, but what it does is when the global community makes a statement about the turf or the area of practice, it helps governments, it helps organizations like WHO, UNICEF to understand what we as pediatricians in the pediatric community believe is the responsibility of pediatrics. So we made the definition quite broad, and I understand in many countries pediatricians do not treat adolescents or young adults, but this was an important statement that we made. And the goal of GPEC is to provide resources to any country that wants in order to improve training. That doesn't just mean to improve things in Africa or in Asia, but in the United States, in Great Britain, in Brazil, all over the world, to shift the quality of training and care, the whole curve this way. So our goal is ambitious, to say the least, but we are making an impact, and I'm going to share some of the results of the first couple of years of our work. It's also important to mention that this is an initiative that was started by pediatricians and is directed by pediatricians. Our goal is to unite the global pediatric community around common standards that we can all agree to, and then move those forward across the world. This slide, which doesn't look like it's showing, sorry. These are the organizations that represent the GPEC Board of Directors. So I want to point out there are several in there. The International Pediatric Association has been a part of this since the beginning, and it's important because it shows the representative nature of GPEC. It's not just a few countries like United States and Australia coming together, but really a global representation. And this picture here shows where our delegates come from. And it's a good representation. I added FOSPECs in there in green because there's a lot of activity in the Southern Cone community, as you'll hear about in a few minutes. But we are a non-profit organization. Our funding comes solely from delegate countries. So delegate countries make contributions to GPEC, and that's how we fund our activities. When we started this process in 2009, we had to develop a basic model of how we were going to develop curriculum, training standards, certification standards, recertification standards. So we came up with a basic model that really exemplifies our vision and our mission to promote quality training and quality health to the world's children. And this is the picture I used to sort of in a nutshell show that everything we do is built upon a competency-based framework. That's our goal, is to build everything around competencies that we as a global community can agree are absolutely necessary to develop quality pediatricians. So you'll see me talk about the various knowledge, skills, and abilities that we as a global community have agreed upon. And the model is built such that it can be implemented anywhere in the world, but tailored to the uniquenesses of a country or of an institution. And I'll give you some examples of that. But at lunch today, we were talking about how healthcare system in Argentina is very different in many places. So the goal of GPEC Board of Directors is to promote this idea of flexibility. Take the global standards and tailor them or make them fit your unique situation. And I have some examples I'll show you in a few minutes. But to give you some background of how we started, we took curriculum and regulatory documents from many different regions, but representing about 50 different countries in the world. And we spent a lot of time reading and going through the many, many lists of requirements and the curriculum. And it was very impressive to us. We spent 3 years reviewing these materials, and it's interesting, there are many countries that have no national curriculum. United States is one of them that does not have a national curriculum. I know that's embarrassing. But some countries had no documentation whatsoever of training requirements or curricula to train pediatricians. So it was a very interesting exercise that we underwent. But curriculum from assessment or evaluation standards, national certification programs, and national recertification programs as well. And ultimately what we wanted to do was to create a document, a tangible something that we could give to the global community, that they could take and incorporate into the training situation, whether it was at an institution, whether it was by a government, or a whole region. And you'll see there are several regions in the world that have adopted GPEC standards across countries. To adopt the standards, we believe there is strength in numbers, that there is strength in solidarity. My good colleague Dioclesio Campos from Brazil is here today, and he is big at promoting the notion that we live in a global community now, right? I mean, everything is global. Commerce, trade, politics. Horace follows United States politics better than I do. So it's a flat world that we live in, and we want to encourage countries to adopt standards. These are the 12 basic areas of competence that we as a group came to consensus. Not unanimous agreement, but consensus. We use a consensus-driven model, not unanimous agreement. Impossible to create national standards by unanimous agreement. More impossible to create global standards by unanimous agreement. So we use a consensus model. But the beauty of these 12 competence areas, I believe, is that there is no one country that actually was training pediatricians to all 12. Some maybe 9, some 7, but no country was training to all 12. United States, Canada, Australia, Great Britain, no. So we took all of the competency frameworks. You're familiar with CanMeds or other competency frameworks. We brought them all together, and then we selected the dominant competence areas that we all as a group felt were necessary for pediatrics. And this resulted in a document with 7 chapters, so it's easy to get one's arms around. And the first 3 chapters, chapters 1, 2, and 3, really define the entire curriculum that countries adopt. Chapters 4, 5, 6, and 7 are guidelines, and I stress there in my note that these are recommendations, not directives. GPEC has no authority to make directives. We provide recommendations as a global community. And chapters 4, 5, 6, and 7 really have taken the best of training materials and national programs from around the world to create very simple, they're very short chapters, but they have very powerful principles that can be implemented anywhere in the world. And what I want to do is very quickly give you just show you what each chapter sort of looks like. For instance, chapter 1, this is how we lay out the basic attitudes and behaviors that pediatricians should master during residency training. So most of the curriculum is focused around residency training, preparing one for practice. These are the core competency areas around attitudes, behaviors, and let me show you one in particular so you can see how the document is laid out, and that is around communication skills. There are some countries that do this much better than others, and we took the best of how countries train communication and interpersonal skills, and we developed these statements that can be incorporated into the training environment, and this gives you an idea here, this page, on what those specific behaviors that we're looking for in residents during training. Chapter 2 are those basic skills and in assessment and diagnosis, in procedures. It's interesting, some countries refuse to document procedures because nobody can agree on which procedures are most important. The United States, we stopped that a few years ago, because nobody could agree on which specific procedures residents should be responsible for mastering. But the GPEC Board of Directors I think, took a risk in defining specific sets of procedures, and I'm going to show you how we laid this document out. We laid it out in two ways. Skills, or whether diagnostic, therapeutic. We have a section that lists those skills, those procedures that residents should be able to perform successfully before leaving the training environment. But we also went a step further, and we pulled out certain procedures that we as a group agreed that may be less important. And again, this is going to vary depending on the practice environment. But in general, these are procedures that we felt was necessary for residents to be very familiar with, but maybe not necessarily master because of the training environment that they're in. Others might perform these for them. So we wanted to build in flexibility, and that certainly is the goal in this document. Now, Chapter 3 is the largest chapter. I think, Horace, you said it was 600 pages in Spanish. In English, it's only 400. So I don't know, did you add extra things or something? I don't know. No, it's a very lengthy document. But what we tried to do is we tried to define the universe of knowledge of pediatrics. So this pertains to the training environment. We also took pains to break it up into these sections because we wanted to make some international statements about. I'm going to give you an example of how we built this document. And it was built over several years with many committees from around the world going through each of these, I think it's 34 sections, very expansive sections. And I'll show you just one section of cardiology. I'm sorry that I didn't translate this, but we basically built an outline of the knowledge, the knowledge that is complete for pediatric medicine pertaining to cardiology. And then we can drill down into more detail, and I'll show you the section on cyanotic disease. And this is just a part of it. This is not the whole thing. And again, I apologize, these are not in Spanish, but I think I have it, yeah. One of the very beautiful things about this document is that we developed learning objectives that are very specific and can really help you create a curriculum for your institution around very specific behaviors and abilities that residents should have. And then we categorized it based on the way we teach medical students. We teach medical students very thoroughly about taking a good history, a physical, coming up with a differential diagnosis, and then developing a therapeutic or a management plan. But in many places, that structure is sort of lost in residency training. So we overlaid that structure in this document. So every section is categorized like this. And I think it's a very beautiful way to organize this curriculum. Chapter 4 is the chapter on the development of training programs. Many countries don't have organized training programs, certainly not at a national level. But even at local levels, training programs, some countries just don't have the resources to develop a formal training program. So I'll show you an example in Africa where these guidelines really help faculty understand how to put together a quality training program. And there are only 7 recommendations, so it's very simple, very straightforward. And I'll show you where you can download these if you'd like. Chapter 5 is a chapter we developed around evaluation. And again, only 6 recommendations there about how to develop an evaluation program for residency training, but also going further into certification and recertification. Chapter 6, there are 4 recommendations for building a national certification program. I know in Argentina, the society has a certification program. In many countries, certification is non-existent. So this takes the best methods from around the world and puts them together in 4 simple recommendations for putting together a program that elevates pediatrics and provides the public with some assurances that pediatricians are well-trained, they're evaluated, and they have some sort of stamp of approval that they're more than just safe, but provide excellent care. And that's the goal of certification. And finally, recertification. This is a concept that really is just gaining steam in many places around the world. And so we had about 5 countries that had really good recertification programs. We put those together into 6 recommendations, and we think they're very helpful, and they're being incorporated in several places I will show you. The curriculum was first published in 2012, and actually we didn't publish it. We simply sent it out for international review and comment. But what happened is countries and regions immediately adopted it. And so we really didn't have time to formally publish it before it was adopted in many places. So that was encouraging to us, but we did get a lot of feedback, specifically from Africa. We had the African perspective in the curriculum, but there were many things we were missing, especially around infectious disease processes. So we received a lot of feedback from Africa and Asia, incorporated that and republished. But we're very pleased with the adoption rate from around the world. It's now available in English, in Spanish, and in Portuguese. It's been translated twice. And I'm going to give you some examples of how it's being adopted in Africa, Europe, and here in Latin America. Am I going too fast or speed okay? Okay. Rwanda, I use this as a very small example, but it was very gratifying to me. Rwanda is still, as you know, recovering from genocide from, what, 20, 30 years ago? So they've just recently started a formal pediatric training program at the University of Kigali. And they were trying to build a curriculum that would fit the African situation in Rwanda when they heard about the global curriculum. And the director called me and said, we want to adopt this and use it to create an African curriculum. I said, great, that's what we want you to do. And he gave me an example. He said, I was just reviewing this document, and you have a section on newborn care, basic, primary, newborn care. He said, our residents don't know anything about this. So he ripped it out of the book, and he posted it on the window of the nursery, and he sent a communication to all residents and said, get a copy of that and begin to implement immediately. And so they changed immediately how they were taking care of newborns in the nursery. It's a small step, but it was very heartwarming to see the encouragement and the passion that this kind of document is being embraced. So in Spain, I love the Spanish people, God bless them, because they contacted GPEC and asked for permission, which they did not need, but they asked for permission to translate this 400-page document. I said, God bless you, yes, please, do it. And they did it in the space of, I forget, 3 to 6 months. They translated it. Many faculty in Spain worked to translate this very expansive document. The beauty of it is then I said, okay, once you translate it in Spanish, you give it to GPEC. And they said, yeah. So then we in turn give it to FOSPEX. And it's translated in Spanish and can be tailored by countries here in Latin America. And what Spain did was they took the curriculum and they were building an electronic recertification program. But they wanted to use the best structure for pediatrics for pediatricians in practice to walk through all of the principal areas of pediatric medicine so that they were current and up to date. So they took the curriculum and implemented it for a recertification process. And that's the website there, Continuum is the name of their program. They've also adopted it for their residency training programs, but that's a much slower process. European Union. If you know anything about the European Union, it's an extremely bureaucratic process in medicine and very slow. For 50 years, the pediatric community has been trying to develop a unified curriculum for training, and no success. They've been trying to develop a unified approach to evaluation, and very little success. So they were developing a curriculum for the European Union when they heard about GPEC. So they put their development on hold and waited for us to finish our curriculum. They took the curriculum, and it was interesting, 400 pages, and they said, no, 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 way too much. And so they rejected it. I said, okay, fine. But then they later went back and extracted at a high level the entire curriculum upon which to build the common trunk. And that's a term they use over there. Common trunk is the, does that translate? Trunco? Common? It's the basic structure of training. So they're now following the global curriculum structure for training in the European Union, but it's going very, very slow, extremely slow. But there's also a group in Europe, the Federation of Primary Care Pediatrics. If you're familiar with this group, these are pediatricians who practice primary care in the ambulatory outpatient setting in many countries in Europe. They contact me and ask if they could take the curriculum and tailor it for primary care in European Union. So they published their own version of the global curriculum designed specifically for primary care in the European Union. It's a beautiful document. They spent a year working on this document. And it sends a message, a bold message, that regions as large as the European Union want to adhere or want to promote the best training guidelines that they possibly can. And GPEC has provided a very simple way for countries and regions to adopt the best practices in medicine. So let me give you an update here in this region, in the Southern Cone region, which was a new term for me personally. I did not know about the Southern Cone, but these are the countries that have been participating, and they have made several formal agreements to adopt the GPEC curriculum and to develop ways to implement it at various levels. And they also have the ALAPE leadership participating in this process as well. As you know, the group is called FOSPEX, the Federation of Pediatric Societies in the Southern Cone region. And this just exemplifies some of the meetings that have taken place over the past 2 years where agreements have been made amongst these 6 countries to adopt the GPEC curriculum and standards and to begin promote it throughout these 6 countries. Now, it's happening at varying rates. I'll show you Brazil is very rapidly adopting much of this, and Argentina to a different degree, but it's happening at varying rates amongst countries. Because of this momentum in Latin America around FOSPEX, we agreed to open up a Latin American office of GPEC here, and thanks to our Brazilian colleagues, they house this office at the Brazilian Pediatric Society in Brasilia. So it's much thanks to them for giving GPEC the opportunity to make a presence here in Latin America. So Brazil began 2013, I believe it was, Dioclesio, and they developed a strategy to begin pilot testing the curriculum and some of the standards and began to implement these in the pilot programs around the country. This is not easy because there were little resources, but program directors have been slowly incorporating the curriculum, and I'll show you some of the wonderful results that have happened. In July of 2013, a wonderful event took place, the announcement that training in Brazil was going to move from 2 years to 3 years. Now, Brazil is the only country that we're aware of in the world where training was so abbreviated, so short. And they had been working for many years to try to increase that training, because I know in the United States, we've come to the place where we think 3 years may not be long enough. We might need 4. You know, it's just, there's so much to teach in pediatrics that 2 years was not enough. So Dioclesio and Eduardo Vaz and others in the leadership in Brazil had been trying to make this change with the government, but could not get that approval. So when the Brazilian Pediatric Society became aware of the GPEC curriculum and standards, they used those standards, they took that to the government, and that was the piece that really helped push them over the edge and helped them to make the decision. And all of these councils and the Ministry of Health and Ministry of Education agreed to provide funding, and now they are increasing training over the space of 3 years. 3 years. They will all use the GPEC curriculum. So this was a great victory for the specialty, and it also provided greater recognition in the government of pediatrics and the respect that pediatrics really should have. So it was a really big win, and they went further and they took the editorial council that creates the textbook of pediatrics in Brazil, decided to adopt the GPEC structure on which to build the next edition of their pediatric textbook. And so Brazil published the GPEC curriculum in this handbook here. There. It's a very beautiful document. It's a handbook, small, you know, about that big. And they give copies to all of the residents, all of the faculty, and it really is used as the Bible of pediatrics in Brazil. And it's linked to the primary text. So there's a linkage there that's quite beautiful. And there is some discussion among FOSPECs to do the same thing in Spanish, to publish the curriculum in Spanish and then develop a similar text. This is in Portuguese, but develop a similar text in Spanish so that you have this linked process from the curriculum to the textbook. We met with the Minister of Education in Brazil in last August to discuss a number of things, but one of them was evaluation. And the government has agreed to assist and is now working with the Brazilian Pediatric Society, and they have created a beautiful assessment program built around the curriculum so that training and assessment are linked. This is a big problem in many countries. Training and assessment are not related well. Someone creates a good assessment, but it's not necessarily linked to the training program because training programs vary throughout a country. I'll give you a good example. In Italy, the residency training programs have certain strengths. So in Naples, most of the faculty are gastroenterologists. So if you're a resident in Naples, what is your strength? Gastroenterology. But you might be very weak in endocrinology or allergy or whatever. Programs can really vary around a country. Then when you come to a national assessment, there's no linkage. So the beautiful thing here in Brazil, what they're doing is they're linking the two together. And Dioclesio, you'll have to help me here if I get this wrong, but they gave some of their first exams. It's called the serial examination. And this just shows the spread of scores. And they were very high, much higher than the current certification exam. And here are the pass rates. This red bar is the pass rates on the certification exam, which is not linked to the training curriculum. And these are the pass rates, greater than 90% for those who have been trained using the GPEC curriculum that's linked to the assessment process. So in 1 year's time, you can see a dramatic difference in the success of trainees, because, face it, it's very discouraging to see pass rates like this anywhere in the world. And this is common. Many countries, pass rates of 50% for certification is common. In the United States, if pass rates for certification fall below 90%, people go crazy. Because if they fall below 90%, it means either we're not training them appropriately, or the assessment is not linked to the training. So this is a beautiful example of how a country, if you have the right people, the passionate people, to go to the government and petition for resources to develop these kinds of programs, you can make a huge difference in how training is completed. So, in conclusion, GPEC is very congratulatory to the FOSPEX community for the way they've adopted and embraced this curriculum and these guidelines. Latin America is truly the shining example in our perspective from around the world, and other countries are watching to see how it's adopted here and the changes that are being made, and it's just wonderful. And we are encouraging all of this FOSPEX community to adopt the curriculum and to consider adopting these guidelines when you develop or further refine your certification programs, your recertification programs. I believe this is almost my last slide. The question, people ask, why should we adopt these? And here's some things I've been thinking about lately. It's good to be aligned with the global community. It's a global society we live in. And being aligned with the global community has great power. As we saw in Brazil, they were able to go to their government and say, look, the global standard-setting body, GPEC, recommends this. We cannot do this in 2 years. We need 3. And it helps governments understand the gravitas, the weight of what we do as pediatricians. We've seen this in a number of places. By adopting global standards, it elevates the specialty in the eyes of government and the public itself. So I think, as I said before too, watching pediatrics lead in medicine is very exciting. And I don't know of another specialty that has developed a program like this in the world around global curriculum and global standards for training. This Alfred Tenor is our chairman from Italy, and he says it best. This is a beautiful process we have with GPEC. It's the global community working together to improve the quality of care for children. And we're very pleased to be a part of your world, and or English. So thank you very much. I appreciate your time.
Bueno, muchas gracias. Excelente la exposición. Gracias, doctor. Yo soy de Córdoba, soy pediatra y trabajamos también en formación y también en relación con ámbitos universitarios. Quería saber qué experiencia han tenido en GP con la relación con las universidades, con sus currículums. Las universidades tienen sus currículums en el posgrado y cómo han aceptado o no la introducción de GP en esto. Y la segunda pregunta es si GP considera también la formación del educador, o sea, de la persona que entrena al médico en sus programas.
Yeah, absolutely. Thank you for your question. Again, one of the best current examples is in Brazil, the way the universities are adopting the curriculum. And Dioclesio, would you like to come up and, no? Okay. Well, it's difficult to implement change in training programs because change is always disruptive. We met with some of the program directors last August to discuss some of the challenges that they were undergoing. But as we all know, if we continue to push forward, the change will occur. And the Brazilian Pediatric Society is giving many resources to universities. They are meeting with trainers many times since April of 2013. They began meeting with trainers and meet with, I know Dioclesio and Eduardo Vaz travel extensively throughout the country, meeting with residency program directors and evaluators, helping them understand the curriculum, helping them think through ways to implement. One of the members of our board of directors was from Israel. He passed away a year ago, but he brought to the board of directors this notion of training for the trainers, extremely important. And it's something that we want to publish helpful resources for trainers. But what we're doing right now is watching Brazil and some other countries and getting feedback on how they are doing this. And specifically in Brazil, they are documenting some of the challenges and some of the successes that they've had. And hopefully, we will be able to document this and share this with the global community, because that's where the rubber meets the road, so to speak, is if your trainers won't engage, it won't happen. But if we can convince the trainers of the value of using a standard curriculum, not only in a university, but in a country. Just think about physician migration. There are many places in the globe, well, the European Union, good example. Open migration, right? No. Because countries train at very different levels. So it's challenging to allow a physician who has been trained here to come into a country where they expect care to be here. A global curriculum, a unified curriculum, a standard curriculum really helps address that. But you have to get the trainers on board. And I said in a talk earlier this week, the only way to do that is to find the evangelist in a country or an institution who will preach this good news about a standard curriculum. And that's what happened in Brazil. There were a few people who saw the value of this and said, we're going to make it work. And they went right to the top and began banging on the door until someone listened and provided the resources. And now they're slowly doing it. So 2 years you've been working on this, and it's still unfolding. It will take much time. The United States is not even considering adoption of this curriculum. They're just watching. It's embarrassing to me as someone from the United States, but they see it as too big a task to undertake. But we're seeing in places that it's not too big a task, even in the European Union with primary care. But you have to find the faculty who will embrace this and see the value and then push it, even without the resources, because many times you won't have the resources. We all say that in training programs. Give me resources, I can do it. No, you can make it happen without resources. You do it all the time. In Paraguay, we see them making great changes in training. It's a little bit at a time, but it's because someone there is passionate about making the change, and they're doing it, and we're seeing results. So, stop there.
Yo creo que, en consonancia con lo que dice el doctor Ham, es uno de los grandes desafíos para el próximo periodo de trabajo en la sociedad, poder unificar el trabajo a nivel nacional, poder capacitar a los capacitadores y poder lograr un currículum global adecuado. Córdoba particularmente tiene algunas cosas que tenemos que pulir, pero que creo que se van a lograr, como es la acreditación conjunta con el Ministerio y con la sociedad, y a partir de ahí poder sentarse con los capacitadores para poder armar un proyecto común, ¿sí? ¿Alguna otra pregunta? ¿Tato?
Sí. Bueno, quería agradecer la charla, que ha sido muy clara y además me deja muy tranquilo porque pensábamos que no cumplíamos estas recomendaciones y ahora me quedo tranquilo que estamos como el resto del mundo. Las competencias deben ser observables y nosotros estamos tratando de ingresar la simulación dentro del programa de entrenamiento de los residentes. Y nos resulta muy simple en el procedimiento, por ejemplo, punción lumbar con equipos, habilidad. El profesionalismo, que la verdad que son las competencias, no sé si es la última por casualidad, y tenemos muchas dificultades en tratar de entender y generar programas de entrenamiento para los residentes en este aspecto. Yo quería saber su experiencia, su opinión, qué herramientas pueden estar disponibles, más allá de esta recomendación de la Academia Americana de Pediatría para directores de residencias de pediatría, que es una recomendación general.
Yeah, it's hard not speaking to an English group, but I was going to say welcome. It's the problem we all have around professionalism. It's in the United States too, very, very difficult. And what we are doing in the United States is the internal medicine community created a beautiful professionalism document. And that's being embraced by all specialties. And it's been helpful for training directors, residency training directors, in thinking through how to not only train but assess professionalism in practice. It is going to be difficult. You can't do it. You can't assess professionalism with a written examination. It's just, but in the residency training environment, there are many opportunities to do that. And so I would recommend that you look at the American Board Internal Medicine Professionalism Project, and there are resources there, not in Spanish, I don't think, they're in English, but that might give you some input. GPEC does not develop all resources. We developed the standards, and we defined the little universe of professionalism that we found was most important. But how to incorporate that, we've not gotten there ourselves. Sorry.
¿Otra pregunta? Sí.
Bueno, muchas gracias por su presentación. Yo llegué un poco tarde, por ahí me lo perdí, pero yo querría saber cómo se integran algunas peculiaridades, ¿no?, que podrían ser los valores que en cada lugar pueden ser diferentes. Por ejemplo, en lugares la investigación puede ser un valor y que esté por fuera de esta consideración general, o estar talleres en comunidad, o participar en una sala de juegos terapéuticos. O sea, cada lugar tiene una peculiaridad, y cómo integra este currículum global esas peculiaridades.
Yeah. Well, the answer is we really do not. What we attempted to do, what I said earlier, was to define the universe as broadly as we could. And then we encourage countries, regions, institutions to take those resources, take that universe, and extract from it what is important for their environment. So, for instance, global health awareness. You don't find that topic in too many curricula in the Western community. You do in Africa. They're very aware of global health, and they think about it much more than we do in the North and in the West. So we took that concept and we put it into the curriculum to open eyes of places that don't embrace or aren't really as adoptive of global health. And there are many other aspects, scholarly activities, as you pointed out. Scholarly work is not a part of many national curriculum or institutional curriculum. And I think we would all agree in this room that scholarly pursuit in residency training and practice is absolutely necessary to be successful, to maintain currency, to understand the literature and how to interpret a basic study, whether it's good research or bad research. But in many places, that's not a part of training. So all we can do is put it out there and encourage people to take it and to tailor it to their unique environment.